Thank you, Burkhard, and thank you, Marconi and George. Wonderful to be here, great crowd, and great information being shared so far today. So I do work with a lot of companies, and some I'll be talking about, including Omeros, Ocular Therapeutics, EyePoint, Imprimis, and Ocular Science. So in an ideal world, we're going to perform lens surgery. We're all fantastic surgeons here in the audience. We get a fantastic visual result, and we don't even need any postoperative meds. That would be amazing, and everyone would be happy. But as we know, we all need postoperative meds in some way to help with our patients. So there are challenges with eye drops. There's an issue with compliance, cost. Some of the generic topical agents in the US can have toxicity to the ocular surface and even have caused melts. But we do know also the rate of endophthalmitis with only topical antibiotics is higher than we would like. Now our goals for prescribing topical antibiotics and anti-inflammatories in general in and around cataract surgery include reducing intraocular and postoperative pain. We want to maintain a nice large pupil. We want to prevent endophthalmitis, reduce inflammation, and prevent CME. But there's some challenges. With the non-steroidal drops, we have choices between generic and brand name drops in the US. Same thing with steroids. There's generic and brand name drops. But then there's also a new intracanalicular dexamethasone medication for steroids. There's sustained release intracameral dex. There's intracameral dex compounded. For the antibiotics, we have drops, both generic and brand name options. We can use intracameral moxie that's compounded. We can use trimoxy, which is a combination of a steroid and antibiotic. We can use compounded postoperative combo drops with all three medications in them. We can use Omidria, intraocular, and we can use subconjunctival Kenalog. And there's probably many other options out there that many of you are using. So it's a little bit of a challenge. There's so many options, but which way do we go? So and there's no one best protocol. And I think at the end you also realize that we all have to, I think things will keep evolving over time. In regards to topical pharmaceutical options, we have many excellent choices in the US. They're safe, effective, and there's a lower dosing regimen nowadays with the more advanced medications available. But there's still challenges with postoperative, with patient compliance. There's still cost issues. And again, if you're going to generics, there can be some ocular surface toxicity issues. In regards to intracameral medications, in the US, we're not routinely all using intracameral antibiotics, even though multiple studies have shown they significantly reduce endophthalmitis. For example, David Chang's wonderful study looking at 100,000 patients in Aravind Eye Hospital found a 4-fold reduction in endophthalmitis with intracameral moxie. There's so many studies in literature that support using intracameral antibiotics. But in the US, we have challenges. We don't have a commercially available intracameral antibiotic, and so we're using compounding medications which have a risk of TAS, which can lead to blindness. We were using vancomycin, some surgeons here in the US, but again, there was this HORV, so that's pretty much off the table for most surgeons in the US. Our option in the US is to use a compounding pharmacy. That's what I'm using at my center. It's a 503B outsourcing pharmacy, so it's a little bit more routine than medication, but still there's our risks since it's a compounded medication. Some surgeons have recommended using a consent form in the US if you're going to use a compounded medication, since there is that rare chance of a compounding error, which could be a problem. Now, what about intracameral steroids? Triamcinolone has been used, but the challenge is it does cause a snow globe effect because it's cloudy and white as it disperses in the anterior chamber. Some surgeons place it into the vitreous. You can still get that snow globe effect there as well, and there's also a risk of increased eye pressure. Dexamethasone is a nice other option. There's a clear formulation for injecting inside the eye for when it's compounded, and there's a new FDA-approved product called DexiQ, which is basically an extended release intracameral dexamethasone. You inject it at the very end of the case. It's a Verisome technology, and it's placed behind the iris. So here's a video by Paul Singh, just showing placement of this at the very end of the surgery. It just goes right behind the iris, and it's going to stay there for about 30 days and really suppress inflammation. So it works very nicely overall. Another option is Dextenza. Dextenza is this ophthalmic insert. It's 0.4 milligrams, and it's placed in the canaliculus. It slowly releases dexamethasone over 30 days, and is currently FDA approved. And this placement of this Dextenza in the punctum, see, it just fits right in. So you want about a 0.4 millimeter size, and it fits right in. And again, it'll stay there. There's fluorescein in it, so you can confirm that it's still there during the postoperative period and hasn't moved. Now, some surgeons are also using intracameral moxifloxacin at the end of the case, along with subconjunctival Kenalog. And this is some videos from Michelle Ackler and Matt Runday that they shared with me, just showing the placement of the subconjunctival Kenalog. It is a pretty good size amount, so patients will notice it afterwards. But some surgeons are able to reduce their need for postoperative medications using this combination. We also have Omidria. This is a combination of phenylephrine and ketorolac placed in the BSS bottle. And so it's FDA approved and helps provide non-steroidal medication at the time of cataract surgery. So you get a nice bolus of NSAID, which is helpful for suppressing inflammation and also for pain control. It's a very nice technology as well. So I think overall we have so many great options. I know if I look around at every one of you, we're all doing something differently. But the good news is that we are doing a great job for our patients. We're controlling inflammation, trying to do our best to prevent infection. And I think, again, this whole area will continue to evolve over time. Thank you very much.